And at that time, people used to always think that pediatric endocrinology is one branch, which is basically very, very rare, dealing with rare, complicated disorder, which require cumbersome evaluation and expensive treatment. This was a common thing. Everybody used to say, what will pediatric endocrinology do? Nothing much to be done at this there. But when we started seeing patients, we were shocked by the way they were being managed. And this is one case with Dr. Rashmi and both of us managed. It was a very short child, diagnosed in 10 years with severe anemia, presented for the first time. And then at that point of time, there was a short stature and was given a blood transfusion, diagnosed as a case of celiac disease, but unfortunately had developed HIV because of the blood transfusion which happened in that scenario. So this was an unfortunate scenario, a case which should have been diagnosed at the right time and should have been managed in that perspective or missed in that scenario. So we thought, what are the problem? Is it a problem of awareness, accessibility, or affordability? Now everybody says it is always a problem of cost. So people say cost is a major problem. But what is the truth is actually the elephant of the house is awareness. If you don't know when should you go, where should you go, how you should be managed, it is difficult. Once you go, direction is there, people will help you. People will help the patient will help themselves, but most important is awareness. So from there, we started our program, and 2012, we had the first PPEC, and a lot of people here, including all the seniors, Dr. Subrato, Dr. Rishi, everybody was part of that program. And since then, we have conducted huge number of programs across the region in the country. But unfortunately, how many physical programs one can do, that is a limit to that. So we started the advanced programs as well. So we moved forward from there to internet media, because now internet is available. So we started on YouTube around 7 years ago. And from there, we moved forward towards a structured program, both on-site as well as online. And now we have got the application and other things which are happening. We have e-learning program, which has got huge number of subscribers, and all of you would have accessed that. This would be something to go forward. But problem with YouTube is that you can see one video and then you forget about it. So if you want to have a systematic learning, we started off with this program of MedEClasses 4 years ago, in which we now have a fellowship program and a diploma program. A lot of programs are there. A lot of people are part of that program as well. Now, we also run regular postgraduate fellow classes, and the publications and applications are there. Applications are going to make very easy day-to-day management in that regards. The often problem which still remains is that the number of pediatric endocrinologists in the country may be around 100, and 100 may be an overrating, exaggeration. Cases are thousands. So what do we need to do? There needs to be a bridge between cases, pediatricians, and pediatricians with special interest, and then more pediatric endocrinologists. This is what we are looking at. For that, now we are trying to come up with a solution, which hopefully will come up in the next 2 to 3 months, which will help you out using a personalized, intelligent EMR. So what it will do is that based upon your particular problem, so if a child has short stature, once you say short stature, specific questions will come with regards to history, examination. This will be there for all conditions. So precocious puberty, delayed puberty, DSD, whatever, 40 conditions we are developing these protocols. You just have to enter these data. Once you enter, you will ask specific questions in examination. So for a delayed puberty, it will ask anosmia. For precocious puberty, it will ask about headache. So different questions will come. Once you answer those questions, put basic data while you are examining the patient. This is looking very benign, simple. You're just putting. But what is, and you can simultaneously assess bone age there. So it looks very simple, you're doing that. But what is happening is that behind the scene, algorithms are running, which are then telling you this is the diagnosis. This is the investigations required. This is the likely treatment. And then you will get a lot of output. And you can then export it in the form of a proper, it will give you like a proper history has been taken. You will get results, interpretation. This is a work in progress. A lot of intelligent algorithms required. It will take time, but this is the way forward. So this will allow everywhere across the country to have a state-of-the-art, quality assured sort of a management, and then there could be connections with clinics as well. So this is something which we are working in that direction. Last 3 days, we had very intense program in the Regency Center for Diabetes, Endocrinology and Research. Over 30 people from across the country had come, and it was a very good interaction with over 300 cases in which a lot of interactive discussions.
Polycystic ovarian syndrome. Now, these girls, adolescent girls with PCOS, always fall into sort of a, they're sandwiched between the pediatrician and the adult gynecologist. And many times, things are actually missed and messed with their management. I believe that there has been a lot of discussion about the diagnosis and the criteria of PCOS. So I'm going to just focus my talk on the management aspect of PCOS. Basically, we all know the three criteria that the Rotterdam and the Endocrine Society mentions about PCOS, which is hyperandrogenism, chronic anovulation, which is persistent, and the polycystic ovarian appearance on the ultrasound, which probably is the most commonly diagnosed thing in young girls, because it is very commonly mistaken the large volume ovaries in adolescent girls, the multicystic appearance, and the fact that we are unable to do the transvaginal ultrasound for them. So very commonly a young girl, if she lands up with a radiologist for a lower abdominal scan, will be written polycystic ovarian morphology. So that is one contentious issue, because very commonly that is found. So to call it as a polycystic ovarian disease or a syndrome, you need to have hyperandrogenism and chronic anovulation in this age group to say that this is PCOS, and it has to be unexplained. It has to be basically persistent. So any cause of temporary anovulation can lead to a polycystic ovarian appearance and hyperandrogenism temporarily. But if it is persistent, then only we label, and it has to be of ovarian origin. So all other causes of hyperandrogenism need to be ruled out before we say this is polycystic ovarian syndrome. Now, the problem with adolescent is that 12% of adolescent girls, due to puberty hyperandrogenism, will have some clinical forms of hyperandrogenism, which could be hirsutism, could be acne. Plus, there is physiological chronic anovulation happening in the first 2 to 3 years of life due to immature hypothalamic pituitary axis. And due to that, you have irregular periods very commonly present in this age group. Plus, the standards are unclear when to start calling them PCOS, who are the patients we say that they are at risk, or who are the patients we know definitely will land up into PCOS later on in life. So the standards are very unclear. And about a third of patients, if you get a scan done, will have actual parameters of polycystic ovarian morphology. So when to say that these girls have actually a very high risk of landing up into PCOS or already have PCOS. So basically the North American Society of Pediatric and Adolescent Gynecologists have actually taken away the polycystic ovarian morphology from the whole equation totally, and given a lot of importance to hyperandrogenism. So if you look at Rotterdam criteria, I don't know if you are aware of the adult criteria, there is the fourth type of PCOS where you have anovulation and polycystic ovarian morphology without hyperandrogenism. Those cases are not taken into account as PCOS in adolescent. So you need to have any clinical or biochemical hyperandrogenism to say that this patient has actual PCOS in adolescent age group. The testosterone cutoffs is 55 nanograms per deciliter for adolescent girls. Moderate to severe hirsutism. So hirsutism is a very subjective thing, and many girls might feel that they are hirsute, but it might not be actual hyperandrogenism. There is idiopathic hirsutism also present. So moderate to severe hirsutism, severe acne, not responding to treatment. The recommendation is that if they've been given vitamin A isotretinoin and yet they are persistently having acne, so those things are a significant hyperandrogenism symptoms. And age-specific irregular periods. So you might have irregular periods in the first 2 years of menarche. And normally they say that generally most of the patients have oligomenoric cycles, that is long cycles, infrequent cycles. And if there is a 90-day, say in the first 2 years, they are cycling longer than 90 days, then we say it is oligomenorrhea. The other aspect of anovulation is also heavy menstrual bleeding. So sometimes they have very frequent, prolonged periods. Even that is very significant in that age group, because that is leading to actual problems. So it is an emergent aspect of anovulation. And plus, it has to be persistent. So a temporary 2 to 3 months period of irregularity will not be regarded as a chronic anovulation, and other causes, and I'm sure all those things have been discussed previously. So what are the goals of management of PCOS in a young girl? First thing is correction of hyperandrogenism, and we all know that even if it is a temporary cause of hyperandrogenism, permanent hirsutism develops because the vellus hairs, they convert into terminal hairs, and it is very difficult to then revert them back. So if there is significant hyperandrogenism, especially in terms of hirsutism, that requires treatment for their current goals. Definitely menstrual irregularity. So there are two aspects of menstrual irregularity. You have patients who present with heavy menstrual bleeding. So that is an emergent aspect. You need to treat it, because otherwise your patient is having a really poor quality of life and land up in anemia. But then there are patients who have scanty periods, which is oligomenoric cycles. In also those patients, because this is a chronic anovulatory situation where a lot of estrogen is there without progesterone, this can lead to basically unopposed estrogen can lead to high risk for endometrial hyperplasia and even to endometrial cancer. So even a scanty period need to be treated if it is persistent, and that is why it is important to manage this menstrual irregularity in these young girls. And definitely, we all know PCOS with their associated, and this is not my field, but metabolic syndrome has to be controlled, and obesity reduction, prevention of type 2 diabetes, and all those aspects are also important in the management of PCOS of young girls. The emergent things would be if you have severe hyperandrogenism, especially which is leading to almost clitoromegaly and all those things. So we need to rule out other causes of hyperandrogenism in these girls, and definitely this causes a lot of problems in the body image of those girls, and which can lead to even sexuality issues, self-esteem issues later on in life. So those having significant hirsutism, even with regular periods, needs to be addressed in this young girl, because it definitely hampers with her overall quality of life. The other, as I already said, menorrhagia is something that needs to be treated emergently. So even if the girl is not fitting into the complete diagnosis of PCOS, we need to treat her, because she will develop definitely anemia and has a poor quality of life. So I'll just summarize the pathophysiology in terms of how we treat it. So we all know PCOS is ovarian hyperandrogenism. The ovaries are tonically producing excess androgens. The majority androgen which is produced by ovary is androstenedione, which is peripherally converted into testosterone in the visceral adipose tissues, mainly the we say that the mesentery is the culprit here. So a lot of adiposity in the abdominal region can lead to conversion of androstenedione to testosterone, and the testosterone definitely causes insulin resistance to be higher, which is already present in obese girls, and PCOS, 50% of PCOS girls have insulin resistance, which leads to decreased SHBG and higher free testosterone levels. So free testosterone is again converted into the active form, that BHT, which acts on the androgen receptors to lead to hyperandrogenism. So these are the various areas where we can work. We can decrease the ovarian androgen production. We can decrease the adiposity where the conversion is happening. We can actually attack the 5-alpha reductase to decrease the conversion of testosterone to active form, or act on the receptor itself. So basically what we do when we use estrogen and progesterone combination, we are using the feedback loop of the GnRH to decrease the ovarian production of hyperandrogenism. So that's how we work when we are using the estrogen and progesterone combined pills, the contraceptive pills. So any pill, and the estrogen part of that pill actually increases the serum SHBG, so decreases the free testosterone levels. So it not only decreases the ovarian production of androgen, it also decreases the free testosterone levels. So effectively corrects the hyperandrogenism of these girls. Plus the estrogen and progesterone combination is basically providing a physiological estrogen and progesterone to prevent the chronic anovulation related effect on endometrial hyperplasia, regularizing the cycle. So these are, the top medications that we use for the management of PCOS. The other aspect would be basically to actually, which is in adolescent girls, the major thing that is to work on the lifestyle. So if we decrease the adiposity in these girls, the conversion of even the physiological androgens that are being produced in this situation. So you have hyperandrogenism of puberty in these girls, especially in some girls, it takes a little longer time to mature. So a physiological situation which is leading to hyperandrogenism in combination with adiposity can actually trigger PCOS. So we can work at the level of prevention of true PCOS in these girls by managing the lifestyle, decreasing the weight, because then we are sort of an acquired sort of hyperandrogenism due to obesity is being corrected. So that is also very important. In some girls where there is very severe insulin resistance, especially obese girls with metabolic syndrome, acanthosis nigericans, addition of metformin gives you a synergistic effect along with both the estrogen, progesterone, and lifestyle to have a better effect, a better metabolic profile in these girls. And last but not the least, you have the GnRH analogs. In girls who have severe hirsutism. It's very rare for some PCOS girls to have a frank, almost a high, what we call as ovarian hyperthecosis, where a very high level of androgens are being produced by the ovaries and all the other methods don't work. Then you can have a complete shutdown of the ovarian function by adding GnRH analogs and correction of ovarian hyperandrogenism. Definitely, you basically how it works is by decreasing the LH and then causing a pseudomenopause kind of a situation. There are drugs that acts on the conversion of testosterone to DHT by attacking the converting enzyme, and then definitely it decreases the hyperandrogenism by decreasing the DHT. And last but not the least, you have certain anti-androgens present where you can use them for correction of hyperandrogenism, and we'll come to that later. Local measures, definitely, because already if the hirsutism is a prolonged, long-standing, you have certain hairs which have already converted from villus to terminal hairs. Those definitely do not revert back, and you need to use local measures like epilation and laser therapy and all to have a complete cure of hyperandrogenism in these girls. And definitely coming to estrogen and progesterone treatment. Now, the first barrier for using this combination treatment in this young profile, generally I find, is because they are marketed as oral contraceptive pills, and usually these parents are, very scared of using pills in the young girls because of a psychological thing that they think. So I never call them pills when I am prescribing. I only call them estrogen and progesterone combination therapy. So when you use the right kind of explanation, they are more likely to take it. Otherwise, they just go out of the room and look for another doctor because they want to not use the quote unquote hormones in their girls. But you need to make them understand why these are important and what is the pathophysiology going on and why this can actually prevent development of a true PCOS in these girls. So mechanism we've already discussed. They decrease the androgen production by the ovaries, also decrease the DHEAS conversion, and definitely SHBG rises, so the free testosterone level is less. Effect is definitely you get a better periods, regular cycles, and also the hyperandrogenism is decreased almost by 30% in the FGS score. So definitely works. So any estrogen progesterone combination pill will work. You need not need to take a EP pill where the progesterone is anti-androgen, and I will come to it. The problem with these pills definitely is that role will correct the oligomenorrhea and hyperandrogenism, but the problem definitely will be high risk for, there are concerns for breast cancer, concerns for thromboembolic episodes, and we'll come to it. So it generally, most of the pills contain ethinylestradiol as the estrogen component. The ethinylestradiol dose in young girls definitely is what we recommend is at least for the bone mass is 30 micrograms. But some girls don't tolerate 30 micrograms. In those, you can use a lower dose, which is 20. The FOXY, which is the Gynae Society, the PCOS committee of FOXY recommends using 30 micrograms because 20 microgram dose basically decreases the estrogen levels to a level where bone accrual will not be optimum. So if majority of girls try to choose a 30 microgram dose when you are choosing the EP pills, only when you have some hypertensives or where you have a CVS risk, where you can choose a lower dose. Some girls won't respond to 30, they have breakthrough bleedings, or sometimes their hirsutism doesn't correct. In those girls, you can use a higher preparation, especially if you have breakthrough bleeding. So a 50 microgram preparation is also available, which is the high dose pills. Higher dose means higher side effects and long-term risks of thromboembolism and breast cancer will also be higher. So majority of cases, a 30 microgram combination pill is what we recommend. Adverse effect, we all know. These are the long terms, but 1 in 10 will also have a lot of nausea, a lot of intolerant to the pill. But usually, if you change the the combinations, usually they are able to tolerate. With the pill, first few days, so first 15 days of treatment, they generally take a time to adjust to the nausea, and usually it goes away in majority of patients. But you can add a few things to cover that. For thromboembolism, it is generally present. The highest risk is present in the first year of use. If in the first year of use there has been no thromboembolism, then the risk is very less. For breast cancer in this age group, the risk is 13 per 100,000 women, which is quite low in terms of current users. And once you stop it, the effect goes down to 2. Okay. So the risk is not very high, and it is only for current users because usually it doesn't cause breast cancer. It only basically picks up people who are genetically predisposed. They anyways would have gone into breast cancer. It is just like pregnancy. So pregnancy also picks up young women who had some needles of cancer in their breast, and just because they got pregnant, the pregnancy actually accelerates that cancer. It's the same effect. So once you stop using the oral contraceptive pill or the ENP pill, the risk is not very high. So it's not that if you've used it for 2 years in your adolescent age group, you're at a higher risk of breast cancer later on in life. It's not like that. It's only for the current users. So within those 2 years of use, the risk is higher. Once you stop, the risk goes away. So the other thing, initiation, definitely, if you have a patient who have a really, severe bleeding or very high hyperandrogenism, you use a higher dose estrogen for the first 3 months. And once the hyperandrogenism, you can, monitor by looking at the testosterone levels. When it goes down, you can come down to a lower dose, which is a 30 microgram dose. But you can start with the 30 microgram dose for all your moderate patients. Definitely, after initiation, we need to see what is the, generally our patients present with amenorrhea. So they've not had period for 2 to 3 months. So you need to give them a progesterone withdrawal and then start the ENP pill. And then follow them up to see whether there are any side effects. Usually the recommendation to use a 3-weekly regimen for majority of patients. There is a combination which is available in a 24/4 regime, but majority of pills available in the market, I'll come to them, are the 21-day therapy. So you give them for 21 days, 7 days off, 21 days, 7 days off. So 3-week on, 1 week off regimen is what is used in these girls. But definitely, if there are patients who have severe hyperandrogenism or menorrhagia, in those girls, you might probably use a very, a prolonged therapy, say a 3-month therapy, 7 days off, 3-month therapy, or 3 monthly periods that you can offer them. Sometimes patients present with menorrhagia. Then you can give them high dose progesterone to arrest the menorrhagia, and then start the estrogen and progesterone combination therapy later on to control their periods, because estrogen and progesterone combination therapy in those doses will not stop the periods. So you need to give them progesterone in a dose of 10 to 20 milligrams for say about 20 days. The periods will stop, and then give a withdrawal bleeding, and then come down to estrogen and progesterone. For estrogen and progesterone to stop the bleeding, you have to give 2 to 3 tablets a day, which causes a lot of nausea. So it's very important to use progesterone to stop the bleeding and then switch to estrogen and progesterone later on. For hyperandrogenism, as I said, sometimes it doesn't work, so you have to use a continuous therapy. Progesterone, the main use of progesterone is that if you use estrogen alone, so as we saw, it's the estrogen which is causing the negative feedback, which is causing the SHBG rise and hyperandrogenism correction. But if you use estrogen alone, then it causes endometrial hyperplasia. So you need to give progesterone to have a regular period. So progesterone is being given only for cycle management, endometrial regulation. It also causes a bit of LH inhibition. It causes the major side effects of the pills. Mainly patient feels that they are gaining weight, fluid retention, bloating, breast pain, cyclical nostalgia, and even acne, because a lot of progesterone have a testosterone effect. So effect on the androgen receptor. So that is why to choose the pill is also important, because the kind of progesterone that you are using, and all the first generation progesterone, which has LNG and norgestimate, those kind of pills actually also have a combined thrombotic risk along with estrogen. So they have a higher risk of developing DVT and stroke when you use those kind of pills. So we'll come to that, what kind of progesterone to use. Effect, we also know definitely in combination they will reduce. So the preparations that are available for progesterone, drospirenone is available, cyproterone. Now these two progesterones are also anti-androgens. They act on the androgen receptor and inhibit the effect of the testosterone. So those are available in combination therapy, not available isolated in our country, but it's available in Europe. Norgestimate, not available in India. And this progesterone is androgenic. So to avoid, if you have a combination therapy with norgestimate, and then you have other progesterones, so you don't get them isolated. They are all present in a combination with estrogen and progesterone pills in the market. So the desogestrel, which is the third generation progesterone, which is commonly available in the third generation contraceptive pills, is less androgenic, and this one is what we will recommend to choose if you are unable to choose the drospirenone and cyproterone because of cost reasons. Coming on to the combination pills that are available in the market, you have the Diane, which contains 2 milligrams of cyproterone. So this is also available in other products like Crimson, and there are Cartella, and there are many products, but this one was the initial. So it contains ethinylestradiol in 35 micrograms. So it is a bit higher dose, and cyproterone, which is an anti-androgen as the progesterone. Yaz is a product which was marketed only for adolescent. This is a 24/4 preparation. It contains estrogen only 20 micrograms and drospirenone 3 milligrams. So this one is basically not recommended by Foxy in India, but it's available in the market because of its estrogen dose. Yasmin, Yamini, there are so many products available in this range with 30 micrograms of ethinylestradiol and drospirenone. Now this one basically, because of its activity, mineralocorticoid activity, is a preferred drug because it also prevents mood swings and all those things that happen. So for the PMDD that happens, so it is one of the drug of choice because of having an anti-androgen. The only problem with this is the cost. So with Diane and Yasmin, the cost is high. For young girls who have period problems and only mild hirsutism, the drug of choice would be something with a desogestrel. So a 30 micrograms of ethinyl estradiol and desogestrel, which is a less androgenic progesterone. It's not anti-androgenic. The cost is great. And this one basically works wonderfully in majority of patients. It only, if this is not working, you can go to the higher progesterones because of the cost. but you can straight away begin with higher progesterone if there is significant hirsutism to have a better cure. Now we also have a cheaper version of ethinylestradiol available. The overall L, the cost of therapy is only 60 to 80 rupees per month. But the problem with this combination is that it has got the first generation progesterone, the LNG, which basically is androgenic, and some women actually, if you give them, will develop acne and hirsutism increases. So you need to choose the right estrogen and progesterone combination to have a better result in your patient. So the effects, menstrual regularity becomes better. Hirsutism gets better only after 6 to 12 months because of the cycle. So the growth cycle of hairs, all the phases, it takes about 6 months. So what the drug is doing is preventing the growth of new hairs. It's not working on the already terminal hairs. So before the patient appreciates that there is something happening with the pill, is first thing is 6 months. So if you have a patient who has really high hyperandrogenism, the better way would be to do a testosterone level after 8 to 12 weeks to see whether the pill is working or not. Because clinical improvement in hirsutism will occur only after 6 months. So that you can do. Basically, menstrual regularity, within about a couple of months, you will see that the cycle becomes regular. And if it is still irregular, it is mainly adherence is not there. Or sometimes the dose you need to increase, because we are using 30, you might go to 35 or 50 micrograms to see if the adherence is not a problem. As I said, when you are doing the test for testosterone, estrogen and progesterone pill is actually a better test would be to do a free testosterone. So better effect is happening via the SHBG. So it is increasing the SHBG, and the free testosterone level is going down more than the total testosterone. So it's important to do a free testosterone level and monitoring in that manner. The duration of therapy, and that is very important and very commonly asked questions, because these girls have chronic anovulation until the time they develop hypothalamic pituitary maturity. We cannot say whether this is the adolescence, the age group that is causing the problem, or whether it is the hyperandrogenism. So we need to complete the therapy till gynecological maturity, and which is now recommended because of the lifestyle changes that the adolescent have had. We used to say that within 2 years, the hypothalamic pituitary axis matures, and majority of women will develop ovulatory cycles after menarche, 2 years after menarche. But now the recommendation is 5 years after menarche, because generally most adolescent girls, the lifestyle is really poor. They are in that age group where they are, sitting and studying for their boards, and, it's really a messy time for them. So usually taking a longer time to mature. So we generally recommend treatment for at least reaching up to the maturity whenever you are starting the therapy. So say 5 years after menarche. So basically, weight loss is another thing. So if your patient is able to achieve at least 10% of weight loss and has a better lifestyle, you can stop and see. So if you are achieving that lifestyle goals, then you can stop and see what's going on with their cycles. And about patients who are at a higher risk of developing PCOS. So when you are in this age group, we generally don't give a label of PCOS to them, because 50% of these patients can grow out of it with weight loss and a better lifestyle. True PCOS patients are generally who have some high risk factors. So you have a family history of PCOS, family history of type 2 diabetes, low birth weight baby who they had premature puberty, or some sort of features of insulin resistance, and those things happening. Those patients are more likely to be true PCOS and will not grow out of it. But there are other groups with mild hirsutism, only period irregularity, no high risk factors, and they're able to lose their weight. Those are the girls who will grow out of it. So very important to identify these patients and keep counseling them, because true PCOS patients will revert back to PCOS once you stop the estrogen and progesterone therapy. Their periods will still become irregular and start having hirsutism and all those things again. So we need to identify who are the patients where we'll be doing. But there is no role of doing the ultrasound again and again. because once you are giving estrogen and progesterone pills, after say 6 months, if you get the scan done, the ovarian size will decrease because the chronic anovulatory picture has gone, is away. So the ovarian antral follicles number will go down and the PCOS will look corrected. But once you stop, again, the whole thing will come back. So there's no role of using ultrasound to tell them that, you know, your PCOS is getting corrected. It's more important to tell them that we cannot say that you have PCOS, but you are at a very high risk of developing PCOS when you grow adult. Very important to correct your lifestyle, have a better weight profile, better lifestyle profile in terms of exercise and all those things. Then only you can grow out of it. So we need to differentiate chronic anovulation due to immature hypothalamic pituitary axis from a true PCOS girls. So that is the most difficult part in the management of young girls. And the other thing is also correct. Any chronic anovulation for a very prolonged period of time, maybe so this girl was not destined to develop PCOS because she had no high risk factors to begin with, but she became very obese during adolescent age group, definitely she will develop PCOS. So prevention and treatment both are happening at the same time, because a very elevated hyper, you know, a testosterone actually switches the negative feedback arm to a higher LH profile, which is, I am sure you probably have discussed all those things in your previous discussions. So it becomes, so even if, example that I give is that a girl who was not genetically destined to develop into PCOS, if she is growing in a mother's womb who has hyperandrogenism, will develop PCOS because of hyperandrogenic exposure to her pituitary and a higher gonadostat. So that's why in this period of time, treatment also prevents development of PCOS. That is important, and that kind of counseling needs to be given to these girls very importantly. Follow-up is only for adherence and to see what things are happening. I generally call my patients after 15 days to look for the acute side effects of nausea, vomiting, tolerability, breakthrough bleeding, and then 3 months after, and then 6 months till the maturity period. Keep counseling. If it was mild, we can stop and see also. Definitely what we have to look for is the blood pressure. About 10% will develop hypertension after initiating therapy, and also look for their things. Progesterone only pills. Sometimes, you know, the mothers are very, very scared of using estrogen combination pills. So if you have a patient who have menorrhagia, then at least we can manage their periods by using these pills. And definitely the indication is when there is no hyperandrogenism, and there is contraindication to ENP because of, you know, the only contraindication for estrogen progesterone pill is cardiovascular disease, hypertension, and personal history of breast cancer. Even if there is a family history of breast cancer, you can use it. It's not a very high risk of developing breast cancer. But if you have a personal history of stroke, of DVTs, of family history of DVTs, those are the patients where you have to be a bit cautious. So you can use the only progesterone pill in those patients. Medroxyprogesterone 10 milligrams. You have got sustained release preparations available also for these products. And you can use micronized progesterone. Generally recommended to use, the effect will be definitely they will stop the period as soon as you use them. But if you stop them, then the period will start again. So it has to be given, say, cyclically, so that you have a regular sort of withdrawal bleedings. No effect of hyperandrogenism of progesterone in that doses. Minimum for prevention of endometrial hyperplasia, you need to give 10 to 14 days every month, so to prevent endometrial hyperplasia. So if you have a patient who has oligomenorrhea and you want to use progesterone just to give her regular cycles, you need to use it for at least 10 days every month so that they have regular withdrawal bleeding. But if you have a patient with menorrhagia and you have to use it for cycle control, you will use it for, say, from day 5 to day 25, 20 days every month to have a better thin endometrium and a better period. They don't have any cardiovascular risk. So this one is the most kindest progesterone. So the progesterones that we are using for period control is medroxyprogesterone, no cardiovascular risk, but they have a lot of fluid retention, so cyclical mastalgia, pain, and those kind of things. So GnRH and Anurag, I will just quickly go through. This is only for who have really refractory hyperandrogenism. Say about only 1% of patients of PCOS we use it when nothing is working. It's the same drug that you use 4 weekly, maybe decapeptyl or leuprolide, even 3 monthly doses. Effect is it shuts down the ovaries, no ovarian production of testosterone, hyperandrogenism is corrected, but it also causes amenorrhea because estrogen is not being produced. So you need to give add back estrogen after 6 months of therapy. Otherwise, there is a problem with the bones. Again, you will have to add estrogen and progesterone after 6 months of GnRH. So very rarely used in PCOS, only for ovarian hypertrichosis patients. Again, lifestyle is the main treatment. This one is going to get them off the pill. So this is the main treatment that needs to be given. Nutritional therapy with regular meals. So for adolescent girls, we don't recommend a lot of keto dieting and starvation diets and those kinds of things because of their bone and the growth potential that they have. But definitely losing about 10% of their adiposity definitely starts their ovulatory function, and definitely all those things I really don't want to go into that. Metformin only indication if there is features of metabolic syndrome and features of insulin resistance. Definitely those you all know, but the combination of metformin and estrogen and progesterone also works better, makes them help in lose weight, and it definitely has some role in adult women where we are using metformin for causing ovulation and correction of fertility. But in this age group, only in patients where you are thinking at a high risk of type 2 diabetes and insulin resistance, only in that cases you will use it, because it definitely has no effect on hyperandrogenism and correction of acne or hirsutism, very minimal effect. So on using metformin isolated for hyperandrogenism correction will not be a great idea. So coming on to basically bariatric surgery, again, I think you guys have all discussed these things only for extreme cases where they have complications, where you want to prevent development of diabetes and severe obesity. Anything which will cause weight loss will correct their chronic anovulation, correct their hyperandrogenism. So definitely obesity related androgenism and hirsutism all gets corrected. But again, in this age group, only for very, very rare cases. So that was the holistic management of PCOS. Now again, some people will not respond to that therapy. So you need to add few other things to decrease testosterone. We can do with estrogen and progesterone by decreasing, but whatever is testosterone is there, if some people are highly sensitive, you can decrease the conversion by attacking the 5-alpha reductase hormone conversion to DHT by using Finasteride, and then Spironolactone, aldactone for attacking on the androgen receptor and correction. Cyproterone, androspirinone, as I already said, also act as anti-androgens. Flutamide is a very mild version of androgen inhibition. Even that works in certain cases that you can use. Aldactone is the most commonly used drug. Spironolactone for people who have not responded to estrogen and progesterone therapy after 6 months, you can add this. But with this, if you're using it alone, it causes irregular period, development of ovarian cysts. So in this age group already, where there is a problem of irregular age group, we do not recommend using aldactone alone for the correction of hirsutism. Always combine it with estrogen and progesterone pill. Plus, this age group, this is a teratogenic drug. So if somebody is sexually active, planning pregnancy, it will cause ambiguous genitalia in a male fetus. So that's why combining with a contraceptive pill will also be a good idea. So prevention of cyst development, regular cycles, that would be additional. But if you're giving it alone, then you have to at least give them progesterone to have a better cyclical profile. Start with 25 milligram dose, maximum dose is 100 to 200 milligrams per day. What you need to monitor in them, they can develop postural hypotension, and they can also develop electrolyte imbalances and liver dysfunction that you all know. Again, any effect on hairs will take a latency period of 6 to 12 months before you start saying that it's not working. Wait for at least 6 months, and then you can add ENP for a combination therapy, which will have a better effect. Finasteride, again, the same. It basically is a 5-alpha reductase inhibitor, and you can give it isolated, but you can give it as a combination therapy. The dose is 5 milligram. The effect is only mild. So only in mild cases where your patient are not ready to take estrogen progesterone pill, you can choose this drug, but it will not have a great effect on other things. Local measures, as I said, will be needed for people who have severe hirsutism, because complete correction of hirsutism is not possible with hormone therapy alone. So you will have to use these methods for a complete cure of hirsutism. So just to summarize, estrogen and progesterone will work on your hyperandrogenism, will work on the period problem, and has no effect on the insulin aspect, where you have to combine it with lifestyle or metformin. Progesterone will only work on the period, no effect on hirsutism or the insulin resistance. Anti-androgen will actually worsen your period problems. So you have to combine, if you have both anovulation and hirsutism, you have to combine it and then give, no effect on insulin resistance. Metformin, if you have a patient obese, high risk for metabolic syndrome, then combine it, but it will have no effect on hirsutism or some effect on menstrual irregularity by decreasing weight and causing ovulation. GnRH analog rarely used, only for severe cases to shut down the ovaries. And just to summarize the PCOS, you have to definitely say whether this is a very high risk case of PCOS, definite PCOS, then you have to definitely start treatment. Look at lifestyle, metformin if there is a high risk for metabolic syndrome, estrogen, progesterone, clinical response in 6 months. And basically, if it is only mild hirsutism where you think that patient is just high, maybe going into PCOS or maybe hyperandrogenism, you need to reassure them that this is only hyperandrogenism of puberty, but there are high risk factors like menorrhagia or severe hirsutism or severe acne, or high risk factors like that this patient was a low birth weight baby, premature puberty, then you need to start treatment for them. And treatment is same till gynecological maturity. Counsel them to lose weight because 50% will grow out of them. But if the symptoms return, then they have to be treated by adult people. Additional anti-androgens can be added if the basic treatment is not working. Thank you.
I think this was a very covering every aspect of hyperandrogenism. Comments from Dr. Ayesha.
Nice presentation, and you have explained such a complex and often debatable topic in such a nice manner. But I believe that managing a child, a person, especially adolescent with PCOS, is as difficult as diagnosing, especially with the current rise in the incidence of obesity. So it becomes more difficult. More adolescents with obesity, they are falsely labeled as PCOS. So what I just wanted to know, based on your experience with the total number of diagnosed cases of PCOS, so how many of them had that they were born low birth weight or SGO? How common is that?
Not very common in the clinical practice, but I think patients who are going to endocrinologists more, they have a lot of low birth weight babies. In our cases, we get more of menstrual irregularity patients. They are less true PCOS. So the majority of walk-in patients that I see are patients with hyperandrogenism due to their lifestyle, and they grow out of it. Only the true PCOS patients who eventually, they are leaner, they have more adiposity. They are not like true obese. They have tummy is protruding, and those kinds of patients, they have more of low birth weight history. They have history of premature puberty also. So those are the patients that I really think that they will not get out of it and they will go and become true PCOS. Yes. Generally, we recommend treatment for patients. Suppose you have a patient with irregular periods and hyperandrogenism, 14-year-old, 2 years of Minaki, and she has these high-risk factors, then definite treatment should be given, because whatever chronic hyperandrogenism due to anovulation will also lead to development of PCOS. And the time limit is generally we recommend at least 5 years post-menarche. So 2 to 3 years of treatment is generally recommended for them. And if they have lost weight, then many of them don't require treatment and they grow out of it. But whenever they gain weight, they get back to the same situation. But if they have not lost weight, they stuck there. You have to, keep using it. Only for mild cases, in the first year itself, we stop and see to, identify those cases who have just hyperandrogenism of puberty. So they are not true PCOS. And then you give 6 months of therapy and their periods are better. So those are the cases that I see most commonly, and they are most commonly misdiagnosed as PCOS. Yeah.
What type of hormonal
Sorry?
Thromboembolic.
No, I have not. In India, I think very, very few cases. All these studies are from Western literature because they have a higher incidence of factor V lead-in mutation. So in UK and Western European patients, I have not seen not even a single case of current users developing DVT or anything in my practice. But definitely there are patients, there are some reports.
Stroke is the most commonly reported one. Stroke will be a common one.
Yeah.
Now I have a question. First
I
of all,
think-
thank you for the very insightful talk. If time permits, just a small query.
Yeah, we'll have just last question because this
Are there
session.
any differences in the management, or is there any complication that we face in the management of mean PCOS? Like, is there any role of myoinositol and metformin in cases of mean PCOS?
Definitely, lean PCOS patients are completely two different category of patients. There are some lean PCOS patients who have some adiposity, visceral obesity. And then there is what we call PCOS type 4. These are those genetic anovulatory patients who have only ovarian hyperandrogenism. They don't have clinical features of hyperandrogenism. So they only present with menstrual irregularity. They have no features of their testosterone levels are normal. So what we call PCOS type 4. These patients will develop infertility later on, but they don't have metabolic syndrome and high risk for those factors. So treatment of both the cases is warranted. For type 4 PCOS in adolescent age group, if they have very infrequent periods, then the chronic anovulation is leading to endometrial hyperplasia. So only for the menstrual correction. It is these patients where you can give only progesterone also. Okay. And the other lean PCOS, which have insulin resistance with them. So you need to identify whether they have those metabolic profile happening. So they are lean, they have a bit of adiposity, and but they are developing hyperandrogenic features. Those are the high risk patients. Actually, these patients will develop a lot of complications, even type 2 diabetes, all the metabolic syndromes. So those need to be treated with both estrogen and progesterone along with metformin to correct all the three aspects of their care. So the periods, the myoinositol basically is sort of ubiquitous drug available, everybody is prescribing. There are no studies available, large scale studies. There are some few studies showing that it decreases hyperandrogenism. Good studies are there in IVF patients when we use myoinositol. The oocyte quality, embryo quality is better. So in adult patients, we are using it routinely. For adolescent patients, very few studies, isolated myoinositol is correcting their hyperandrogenism. I think they are those patients, as I said, the mild cases of puberty hyperandrogenism. They are not true PCOS. I generally don't use it in a patient which is high risk, has chronic anovulation. So isolated use of myoinositol, no role in adolescent girls yet. But we don't know what it comes out. The studies are happening.
I think we'll just close on this last question from Dr. Satyakala from Melbourne. She's asking management of primary amenorrhea in PCOS. whether you will give E plus P or just progesterone. So presenting with primary amenorrhea. We do see some cases.
Yeah, definitely. Primary amenorrhea or oligomenorrhea, it is one of the same spectrum. Now, this is just a rare patient who has never had a period, but she is chronic anovulatory. And if she has hyperandrogenism, then you will have to give both E and P. And if she is just primary amenorrhea without any features of hyperandrogenism, she is probably the PCOS type C or type D, where, you know, there is only genetic chronic anovulation without any insulin resistance, then you can use progesterone also. But the first priority is to give them estrogen, because this is a time where they need estrogen for their bone accuracy. So I would be, in my 95% patients, I would try to push for estrogen and progesterone because they are the safest drugs. Only for those patients who have high risk for cardiovascular, high risk or hypertensive, or where the parents are not ready, only in those cases I will go for progesterone.
So just withdrawal and then you start with estrogen progesterone.